Hello, everyone. Good evening, good afternoon, good morning, depending on whichever part of the globe you are in now. A great pleasure once again in welcoming you all to yet another session of State of the Art in Neonatology, organized by Learn from the Legends and Neonatal Expert Talks, or next series by National Neonatology Forum India. Thank you so much for joining us today. Before we move on, may I request Dr. Surendra Singh Bisht, Honorary Secretary General of National Neonatology Forum India, to speak a few words on behalf of NNF India. Over to you, Dr. Surendra.
Thank you, Manoj. I think Dr. Praveen Kumar has joined, and it will be very prudent for Professor Praveen Kumar to welcome Dr. Vineet Bhandari, who happens to be from PGI himself, I feel. And sir, are you there?
Are you there, Praveen sir? I did not see you. That's why I did not call you.
Sir.
Yeah, thank you, Surendra. Thank you, Manoj. And good evening. Welcome, everybody. And welcome, Vineet. Great to see you, as usual. Cheerful, bright, and we have always enjoyed your talks. And we're grateful to you again to accept the invitation for this talk. And I know whenever we call upon you, you are always ready. And I think we have always learned, enjoyed, and of course I have very pleasant memories of knowing Vineet since early 1990s when we worked together. So thank you very much, and thank you Manoj and Surinder for carrying this series forward. I would hand over back to you now. Thank you.
Thank you, sir. Friends, now I have great pleasure to introduce the moderators for today's session. Dr. Giridhar Seduraman, a good friend of mine and a professor of neonatology from Chettinad Hospitals, Chennai, India. And Dr. Murali Raj, another good friend of mine and consultant neonatology from Cross Hospital, Kodungalur, Kerala, India. Hearty welcome, both of you.
Thank you, sir. Thanks for the invitation.
Now it's my honor and privilege to introduce and welcome the legend of the day, Professor Vineet Bhandari. Dr. Vineet Bhandari, MD, DM, completed his medical school from the Armed Forces Medical College, Pune, India, followed by pediatric residencies and neonatology fellowships from the Postgraduate Institute of Medical Education and Research, Chandigarh, India, and the University of Connecticut, USA. He then worked at the Albert Einstein Medical Center in Philadelphia and Yale New Haven Children's Hospital, New Haven for more than 20 years, before becoming the Chief Department of Neonatal Perinatal Medicine at St. Christopher's Hospital for Children, Hahnemann University Hospital and Temple University Hospital, Philadelphia, and a professor of pediatrics and obstetrics and gynecology at Drexel University College of Medicine in 2015. In 2020, he joined the division head of neonatology at the Children's Regional Hospital, Cooper, as Vice Chair of Pediatrics for Faculty Development, Professor of Pediatrics, Obstetrics and Gynecology and Biomedical Sciences at Cooper Medical School of Rowan University, Camden, New Jersey. Professor Bhandari has edited 3 books, Manual of Neonatology, Bronchopulmonary Dysplasia, and Tantalizing Therapeutics in Bronchopulmonary Dysplasia, and authored over 335 books and chapters in and original research articles. It is amazing to know that he managed to get funded all the time by NIH since 2003 for his research projects. And he has presented his research in many national and international conferences. It shows the quality of the research that he has done. Hearty welcome, sir, to today's session. Friends, Professor Bhandari will discuss a topic of interest to all of us, the art and science of extubation success in NICU. Now I hand over to the moderators, Dr. Giridhar and Dr. Murali Raj. Over to you, Giridhar. We may start with the poll.
Thank you, sir. It's a pleasure to welcome Professor Dr. Vineet Bhandari. I think to know about respiratory medicine in neonatology, I think there's no better person than Professor Vineet Bhandari, because we have to hear from the horse's mouth. So without much ado, let us go into the poll first. Before we start the session, I think the delegates can take up this poll, and we'll see the responses in this poll. Basically, this is a question which has been given by Professor Dr. Vineet Bhandari. For primary respiratory support, do you use NIPPV as a primary respiratory support in neonates? So people have the option of only choosing one option. Either it is sometimes, always, or never. Please, can you please click on the answers so that we can have the responses from the delegates?
Another 10 more seconds, we'll close the poll. Shall I close? Yeah.
So I think the predominant responses are for NIPPV use as sometimes. 57% of the respondents have gone with this choice, whereas 33% have told that it's always NIPPV. And at least it seems that only 10% of the delegates attending here have never used NIPPV as a primary respiratory support in units. So I think, Professor Sir, it's over to you, sir.
No, next question. One more question.
One more question is there. Okay, I'm sorry. Yeah. So can we close this question, sir, and we'll go to the next one?
Yeah, it's not closed yet. Eh?
No, sir, it's not closed.
Yeah.
So this is the second question. So now we want to know how many of people use NIPPV as a respiratory support post extubation in units. Again, the choices are sometimes, always, never, and others. Please start polling. Just give 5 more seconds, sir.
Yeah. I think that's it. Let's see.
Again, sometimes seems to be the predominant choice of the delegates here. 60% have told that they use NIPPV sometimes for post-extubation. 36% have told always. So I think people, 96% of the people are using NIPPV either sometimes or always. The response of others are very meager. So that completes the poll questions. And can we invite Professor Vineet Bhandari, sir, to share his screen and start the lecture, sir?
Can you, thank you so much. Can you see my screen now?
Yes, sir, your screen is well visible, sir.
Okay, excellent. Thank you so much for the invitation, Manoj, Surinder, and Praveen. And thank you to the moderators, and thank you so much for the kind introduction. I apologize for my voice. I'm at the end of a cold and I have a little bit of laryngitis, so I will be sipping some nice green tea. Trust me, it is nothing else in there, just tea. Hopefully in the next 45 minutes or so, we are going to have some discussion, or at least presentation from my side about the science and the art of extubation success in the NICU. Looking at the poll results, my aim is that hopefully by the end of my talk, and hopefully a discussion at the end of it, that there will be 0%, at least of the delegates who are here, who answered the poll, that who will say they never or no, don't use NIPPV at all. I want that number to go down to 0%. And I'm hoping the one that said sometimes or always, we had somewhere between 60% or so for the sometimes. I want that number to go up to about 75%. And for the others who, hopefully down the line, in a few more years, they'll become 100%. But hopefully I will be able to convince you, showing you the data, why the science behind this non-invasive support is so strong. And the data has been accumulated over, I would say, more than 25 years now to support what I'm going to try to tell you. Okay. All right. Why do we want to, I hope you can see my second slide about the pathogenesis of new BPD.
Yes, sir.
Excellent. All right. Why do we want to focus so much on non-invasive support? Well, I think we all understand that BPD is a big problem for us, and where it is not a problem, if as you start seeing the smaller babies, it will become a problem. So BPD is a complex disorder. There is genetic predisposition and epigenetic modulation, and the start of BPD happens, obviously, probably you could argue, given the genetic predisposition at conception, but definitely there is some antenatal component to it. You have chorioamnionitis, placental problems, and other stuff that could be contributing. What I want you to understand that while we talk about BPD as a yes or no phenomenon, the propensity or the tendency to get BPD, one should always think of it like a speedometer dial. So you have the extreme end, you have the resilience or the resistant, maybe genetically, or you have some increased vulnerability. And this resilience or vulnerability has different gradations as denoted by the speedometer dial. Anyhow, once the baby is born, we are going to expose the baby to supplemental oxygen and the focus of today's talk, invasive positive pressure ventilation. The combination of the genetic and these two very important environmental factors, and of course there is inflammation that's going to come into play, is also contributed by infection. Now there are modulating factors. There is the breast milk feeding, microbiome, vitamin A, and all the other factors which I've not listed here, but some of them are listed, caffeine and postnatal steroids, that are going to modify this inflammatory response. The timing of the inflammatory response is very critical for the baby to get BPD or not get BPD, or at least have the decreased or increased severity of BPD, notwithstanding the factor that you have an inherent tendency to get BPD. But the modulation of these factors are very, very critical. And what I'm going to try to impress upon you is that if we can modulate the invasive ventilation factor, it can potentially improve or decrease the amount of tissue damage, and which will hopefully try to prevent you from getting severe BPD, hopefully even prevent BPD in certain circumstances, but if not, at least try to prevent severe BPD. How does invasive mechanical ventilation lead to lung injury and BPD? This is from my textbook in bronchopulmonary dysplasia. And you can see that the variety of factors that are involved, and they release, and it acts on different types of lung cells in the body. I'm focusing here on the inflammatory cells, endothelial cells, epithelial cells, fibroblasts. All of this, they release a lot of pro-inflammatory cytokines. And the balance between the pro and anti-inflammatory factors affects the degree and the persistence of the inflammation. The more a foreign body stays inside your body, the more likely that you will get more inflammation. And I will highlight this many, many times in my talk, that the timing of this inflammation and the variability in the response of the body to this inflammation is very, very critical in how we get BPD. This is just highlights the same fact that I've just mentioned. It shows you sensitivity and 100 specificity on the x-axis and sensitivity in the y-axis. As you can see, the longer you spend your time on invasively ventilating, the more likely you're going to get BPD. Timing is everything. This is a nice picture I got off the internet, which just shows you how the delivery of the baby by the stork is to the, in this case, the father's hands. And the photographer hopefully didn't Photoshop it, but I'm assuming he was able to time the photograph that when the stork was flying over, the baby had been sent up into the sky to be dropped off, so to speak. And then, of course, he's very happy to be caught by his father. So timing is a very critical factor, and I will highlight that throughout my talk. And I want to emphasize that the timing of when you extubate the baby becomes very, very important to try and mitigate this tissue damage that the lung will get if you have kept the baby intubated. So we did a study many, many years ago. It's a retrospective study. We said, let us see what the baby support has been at 24 hours, day of life 1 to 3, and day of life 4 to 7. And we divided it into 3 categories: endotracheal tube, NIPPV, and CPAP. And we said, what are the chances? How many of these babies who are getting this types of support get into BPD? So you will notice here that at the 24 hours, if you are on CPAP, you have less chance of getting BPD. And day of life 1 to 3, if you're intubated, you have about 67%. And of course, if you have day of life 4 to 7, ET tube in place, you have 81% chance of getting BPD. This decreases dramatically. In fact, within day of life 1 to 3, you can see the NIPPV rate is a little bit lower, not significantly lower. And of course, they're about the same than ET tube. So the point I'm trying to make is that if you don't have the endotracheal tube in place, if you have CPAP or NIPPV, you can support the baby and not keep the endotracheal tube, you can make a difference. And again, it looks like the critical time frame that this needs to get done, at least in terms of this study, was 24 to 72 hours. Let's get into a little bit more detail about that, because you could say, well, the baby, you might be able to extubate the baby. What happens if you have to reintubate the baby? Okay. So this basically is what's called a Kaplan-Meier or a survival curve. And on the y-axis is the probability of no BPD. And on the x-axis is time from first extubation. And you can see the color coding: the blue for day of life 1 to 3, the red for 4 to 7, and the teal, dark teal color for day of life 8+. You can see very clearly that the big difference between the blue and the red compared to the dark teal color. And if you're extubating in the day of life 1 to 3, you have the highest probability of no BPD. So that is where I'm going to be focusing on, that if you have to make it looks like, at least in this study, based on this study, and I'll show you another study that we did at the follow-up, that if you are at the first 24 hours, you have this, it's okay if you need to keep the tube in. If you can take it out, even better, but at least make an attempt to try to get the tube off between 1 to 3. And so I'm going to try to get into the science of why that is necessary and how do we do it successfully. Okay, what is the difference it makes having a tube in place? So this is the data for unadjusted survival of BPD, but I'm going to be focusing on the second table here, which is the adjusted survival in terms of BPD. And it has been adjusted for a variety of factors that we could find and we collected data for. And we hope that this at least makes the data more robust and the results more convincing. What you see here, if you compare day of life 4 to 7 to day of life 1 to 3, having an ET tube or not having an ET tube, your risk of BPD is about 2 times. It is statistically significant, right? Day of life 8 versus day of life 1 to 3, it is about 13 times more likely to get BPD. Day of life 8 and day of life 4 to 7, almost 7 times more likely to get BPD. So either way, even if you're not able to extubate the baby within 24 hours, within day to life 23, what the data is suggesting is that the longer you're keeping the ET tube in place, the more likely you are, and the risk increases exponentially. You're increasing the risk from 7 times to about 13 times, almost double, if you keep the tube in longer. And people in the good old days or bad old days used to find so many reasons to keep the tube in. Well, the baby will get tired. I may have to reintubate again. The baby will grow better when the endotracheal tube is in place versus on non-invasive support. All those 3 reasons are not valid. And I will show you scientific evidence to prove that for you. Okay, this was the follow-up study that we did a few years after the first study. We wanted to see, okay, let's make an effort to take the tube out. What happens if they get intubated, right? So we are going to compare 3 groups here: day of life 1 to 3, 4 to 7, and day of life more than 7, right? And you can see how many babies have extubation failure. So if we extubated the baby between day of life 1 to 3, we had 70% extubation failure, okay? And these are small babies. I mean, if I remember correctly, these are babies less than 1250 grams or less than at least 32 weeks, if I remember correctly. But the point here is that, yes, there is a high chance of failure. We have gotten better at it. Actually, our failure rate is no longer that high because we've been more aggressive with NIPPV. But let's just stick to this data over here and show what happens. So I'm going to compare the ones who failed. So they got extubated, day of life 1 to 3, the tube went back in, and I'm going to compare with the babies who did not fail extubation when we extubated between day of life 4 to 7. The argument here is saying that, okay, if you're going to fail extubation in day of life 1 to 3, let's keep the tube in for a few more days and we'll extubate when we are more sure, and let's just take the tube out. Okay, what happens with the risk of BPD? Well, you see that it doesn't make a difference in terms of the risk of BPD. So just the fact that you have reintubated the baby after failing extubation in the first 3 days of life, does not significantly increase the risk of BPD. So again, trying to tell you that it is relatively safe to do that. Let's move on to the next one. What happens if you say, oh, I want to be very safe, I'm not going to extubate in the first 3 days, I'm going to wait till the baby is definitely in a much lower setting than I'm going to wait for more than 7 days. Here, you're going to increase the risk of 8 times to get BPD. Once again, I repeat, these are the babies who failed extubation in the first 3 days. So we have put in the tube back in, and we have followed these babies up till they reach 36 weeks post-ventral age. Even at that point, it is better for these babies to get reintubated, but you have managed to at least keep them extubated for some period of time in the first 3 days of life. The risk of BPD is much lower, significantly lower, 8 times lower compared to the one that you will keep intubated beyond 7 days. All right, let's talk about day 4 to 7 versus that. And once again, it is better that the babies have been, attempt has been made to extubate between day of life 4 to 7. And even if the reintubation has happened 80% in this case or 79% in this case, it is still better off in terms of risk of BPD than keeping the tube in place. All right, so just to summarize that part of the data, when adjusting for multiple relevant factors, extubation day of life 1 to 3 is associated with a significantly reduced hazard of BPD compared to day of life 4 to 7, right, or beyond 7 days. Even when if you, for whatever reason, you're not able to extubate day of life 1 to 3, try to extubate the baby between 4 to 7, because even when you do that, it is significantly reduced hazard of BPD when compared to extubation beyond 7 days. This is a very critical part of my talk, and I will highlight that now, and I will highlight that again in the end. Reintubation rates do not significantly differ across study groups. Very importantly, babies who fail extubation and need to be reintubated are still at a lower risk of BPD than babies who are first extubated later in life and do not need to be reintubated. We were the first folks, as far as I can remember, that we, of course, we did it was based on retrospective data, but we said this and emphatically said this in 2014. And after that, there have been at least 2 other studies with much larger sample sizes that have reiterated the same point. And again, this is from Jensen's group, which is a huge data set. I think they used one of the commercially, I think it was called, I forget the name, but it was many, many babies across many centers where they have done this. And what I want to highlight is the thing that says that our findings suggest that reinitiation of invasive mechanical ventilation does not increase the risk of chronic disease. A practice of routinely trying extubation when low ventilator settings are reached, even if extubation success is not guaranteed, may reduce the risk of lung injury and BPD. It has also been reiterated by a study from the Nationwide Children's Hospital from Ohio. And this was a study in 27 weekers, less than 27 weekers, and 64% had to be reintubated, very similar to the number that I've shown, about 60%. Every day first extubation attempt is delayed, it costs the hospital $4,500, which, for the hospital, it may not be a bad thing because they're making money. But from my point of view, that is not cost effective. Older the infant at first extubation, the more likely they will have moderate to severe. So the longer you wait, even for the bigger babies, you're going to get more problem. More importantly, reintubation was not associated with either mortality, moderate to severe BPD, or increased mortality, or increased moderate to severe BPD, or length of stay. So my request to you is, for the folks who do not use it or use it sometimes, please make an attempt to extubate these babies in the first 3 days of life. The baby will thank you for it, and I obviously will be very grateful to you for doing so. Okay, now that the question is that hopefully I have convinced some of you or most of you that non-invasive support is helpful. But I'm again focusing on the folks who are between the 40 to 60% who said they don't use an IPPV. Well, they may be using CPAP and stuff. So what are the different types of non-invasive support we can give these to babies? So I like to divide them into variable airway pressure and constant pressure. So under variable airway pressure, the first one is nasal high frequency ventilation. and in most circumstances is nasal high frequency oscillatory ventilation. And I'm going to show you some data about that. The next one I would have called is SNP or NIP. Now I have put the synchronized in quotation in parentheses because I, in my unit or in the USA, really don't have synchronized NIPPV, and I use only non-sync. And I think that the data, and we have shown this, between SNP and NIP, we are still getting very, very good results, even with NIP, as long as you do it well, the way I would like to say, I would like to advise you to do it. Synchronized is obviously would be better, but we do not have the ventilators in the US. There are ventilators available, like for example, in Italy and other parts of the world. Julia ventilators is supposed to be able to synchronize with the flow when you are on the nasal prongs. I have a little bit of experience with it when I was in Italy. I don't have experience with it in the USA with that machine. Hopefully, folks who have them access to the machine will do it, use it, and then will produce the data to support it. I will talk about NAVA separately. The other next level of decreased support would be what I would say BiPAP or CiPAP if you're synchronizing it. And then, of course, we are going to, I will not talk about nasal pressure support ventilation because there's a very little bit of data on that. Now, if these are what I consider the highest amount of pressures that you can give to a baby, especially if you are doing non-invasive support or through the nose. When you come to the constant airway pressure, you have this varieties of ways of giving CPAP. It can be variable flow, bubble CPAP, ventilator CPAP, and all the different methods of giving CPAP. And I will try to give you some data on that. And after that comes high flow nasal cannula. By that, I mean more than 2 liters per minute flow. And then, of course, 2 liters to up to 8 liters per minute. Then, of course, we have low flow cannula. I'm going to try to touch on most of these factors and show you data. Most of them is going to be composite data, meta-analysis, the Cochrane reviews, to hopefully convince you why one is preferred over the other and what does the science support in terms of selecting which support should be done initially. Okay, so this is with nasal high frequency oscillatory ventilation and CPAP post-extubation meta-analysis. And you will see I will use pretty much the same format. Hopefully all of you are familiar with this. You have, one, the odds ratio, and then you're going to look at left or right. And of course, if anything touches 1, it is not significant. And when you look at need for intubation and mechanical ventilation and PaCO2 levels, this actually does not touch this number 0. So it's definitely both most to the right, to the left. And so what we find that the likelihood of decreasing the need for intubation and mechanical ventilation and increased elimination of PaCO2 levels compared to CPAP, nasal high frequency oscillatory ventilation seems to work better. There has been some data, as far as I know, only 2 pieces of data I'm aware of that have done randomized controlled trials. And here is comparing nasal high frequency oscillation with NIPPV with CPAP. And you can see that there is some significance. Oscillatory ventilation CPAP, they have found significance over here. And then also the same with NIPPV versus CPAP, but this has been shown even before. And of course, with high frequency and CPAP. However, in the second study, which is a different group, you find that they did not find any difference between high frequency oscillatory and NIPPV. I think the data supports that if you are comparing nasal high frequency oscillatory ventilation versus CPAP, it probably will decrease the need for invasive mechanical ventilation and eliminate CO2. I think that there needs to be more data in terms of comparison with NIPPV. And once again, there are different ways of giving NIPPV. And I will use the word, I've published guidelines on this and how much pressure I will use and what higher pressures I will go to. And I would strongly suggest that you take some time to read those guidelines. Happy to talk to you later or even come to a unit and show you how I do it. But if you use homeopathic doses of NIPPV, you are not going to get the benefits of NIPPV. It needs to be done with the proper safeguards in place, which I will mention, which is where the art of ventilation of NIPPV, or at least non-invasive ventilation, will come into play. All right, in terms of primary mode of nasal high frequency oscillatory ventilation, there is at least four pieces of randomized trials that have been evaluated. Now they have compared it with CPAP, and they can show here that the outcome in terms is better in terms of not needing intubation when you do nasal high frequency oscillatory ventilation as the primary mode versus CPAP. To my knowledge, there is no primary mode nasal high frequency ventilation versus NIPPV studies done so far. Okay, what about NIV-NAVA? Now, NIV-NAVA, again, hopefully all of you are familiar with NIV-NAVA. neurally adjusted ventilatory assist, which is, with the mode of ventilation where you have the sensor in the OG tube, which detects the electrical activity of the diaphragm and synchronizes it. And you can see over here, when they have compared NIV-NAVA with NIPPV, again, very small sample size, there is no difference in the outcomes that they have listed on the left side of this table. What about NIV-NAVA versus CPAP and RDS? And these are randomized controlled trials that I've looked at it. And let me see, I think I've highlighted a few things here. So, sorry, let me get my reading glasses on here. So you can see over here that when you compare NIV-NAVA with the control, at least in these parameters, they have not shown any significant difference. But in terms of the need for endotracheal intubations, also there is no difference when you compare CPAP to NIPPV. The number of sample size of these studies are small. So I think more data needs to be gathered, whether we can say for sure that it is better or not better, or whether it is more useful. And once again, keep in mind, they are comparing it with CPAP. There is some improvement over here in terms of duration of invasive ventilation when you compare the NIV-NAVA group versus control group. But here the benefit is actually in the control group, which was CPAP, if I remember correctly. And in this situation, it is also the similar way that here the NIV-NAVA had the better outcome. So again, these are conflicting results that are coming up in these randomized trials. And these are fairly recent studies. So I think more data will need to be gathered about this to be sure about what is going on. Let's talk about bubble and ventilator CPAP. This was published in Indian Journal of Pediatrics a couple of years ago, randomized trial, demographic data. And basically they found no difference when they compared ventilator CPAP with the bubble CPAP in the extubation failure or the median time to extubation. Another study published a few years ago, again, no difference in CPAP failure, air leak syndrome, total CPAP time, oxygen time, or duration of hospitalization. All right, now let's move to high flow, high humidity nasal cannula. Again, I'm not going to go through details because this article is very, very useful. And I would recommend that you look over it because they have done a great job in summarizing the data. The bottom line is, if you look at it, there is essentially no significant difference. And in fact, where they have tried to compare it with CPAP, they have actually found more failure rates with the high flow cannula. And this data, I think, is very useful. This was a randomized controlled trial published in 2016 in NEJM. And here you can see that when you look at the treatment flavor of failure in the high flow group, it is 25% versus the CPAP group, which is 13%, which is highly significant. And this is true whether you break up gestational age into high and low groups. And treatment failure within 72 hours, which is my golden time frame, 24 to 72 hours to get ready to extubate, was much, much higher with the high flow group versus CPAP. So essentially, I would not recommend using high flow. And there are other reasons for not recommending high flow, which I will summarize when I show my summary slides, versus at least CPAP. How does NIPPV work? Well, NIPPV works by washing out the pharyngeal dead space, reducing the inspiratory resistance, stability of the improves the stability of the chest wall, decrease work of breathing, opens up the collapsed alveoli. And I'll show you pictures or x-rays to show that this is actually true. People think that NIPPV is just glorified CPAP. It's not glorified CPAP. Not only does it give higher pressure than constant CPAP for obvious reasons, because we are using higher pressure, but more importantly, it actually washes out CO2. And you have to be careful. It's not as good, obviously, as the oscillator in washing out CO2, but definitely much better than CPAP in washing out CO2. And so you need to make sure you monitor the CO2 levels when you have a baby on NIPPV versus, let's say, on CPAP. When the different ways of synchronization, I already mentioned to you, the one that I am most familiar with was using the Grace-P capsule, which was a sensor which was placed with a belt over the baby's abdomen through the right side, just below the diaphragm over the liver, and that would detect it. It is a very good method of detecting the breathing effort because the diaphragm is the main muscle of breathing for the baby. And that would, we'll transmit it to the ventilator, which is the star sync with the synchronized module. And that would then synchronize with the baby's breathing. It worked beautifully. Unfortunately, the company took away the sensor and the machine, and I don't have access to it. And I did try to talk to them many times, but it's a different company, bought another company, Maybe they will bring it back, but I can tell you that technology works really, really well. I already mentioned about the flow synchronization. The only ventilator that I'm aware of is the Julia ventilator, which measures the flow at the nasal interface. Keep in mind that the nasal interface flow is very small, and so it's not very easy to do it. But that machine, at the end, limited experience, my own limited experience, but I've been told that it works reasonably well. The NAVA, of course, is a very, very good sensor of detecting the electrical activity of the diaphragm, and it obviously picks it up very, very nicely and synchronizes. Personally, when I've used the NIV-NAVA mode with the ventilator, I have not had good success with it. Of course, it synchronizes beautifully. In fact, when I have used it in the invasive ventilation mode, I have been able to decrease the pressure than the vent settings and oxygen. But when I've used it in non-invasive ventilatory mode in the NAVA, I have not found it superior or anyway better for me, at least in my hands, when I've compared it with NIPPV the way I use it. I have to mention that I have not used or have access to NIV-NAVA for many years now, so I do not know if they have made improvements in the algorithm and the software. And so if that is the situation, it may be better, but at least in my hands, at least from 5 years ago, 6 years ago, it has not been shown, at least in my hand, to be better or superior versus NIPPV. All right. This is what I basically was trying to ask you when I requested the poll to be done. And you can see over here that I divide NIPPV into primary and secondary mode. My primary mode is that when you use it right from the birth, which is basically using a T-piece, which is, as you know, you have PIP and PEEP and you are ventilating the baby versus CPAP. And then continuing that in the first 2 hours of life, you may be intubating and using Insure to give surfactant, or you are using Lisa or MIST or however you want to give the surfactant, but then you place the baby back on NIPPV. So that's what I consider primary mode. Secondary mode is that you've kept the baby intubated for hours or days or weeks beyond 2 hours. And then you say, oh, the baby has low enough oxygen settings and ventilator settings, let me extubate it, and I extubate to NIPPV. You will notice that I use much higher pressures when I'm primarily using it. So whatever pressures you're using with the T-piece or when you're bagging, I will go 4 centimeters higher than that. And that is just my starting point. And I will listen to the baby. This is where the art of extubation comes. You listen to the baby, listen to the axilla, especially on the right side, because that's where all the 3 lobes meet. Look at the expansion of the chest, make sure the saturations are good. Look at the FiO2 requirement. I always like the FiO2 requirement to be less than 40%. And if the FiO2 requirement is more than 40%, then I am increasing the pressure. Whether I increase the mean airway pressure. Now, whether I'm increasing it by using higher I times or increasing PIP. PEEP, I don't like to increase beyond 6, sometimes 7, but that's pretty much the maximum I will increase, right? Note the fact that I will start with an I time of 0.45 and I will go up with I time of 0.55. I tend to use the higher I times because I want the PIP or the pressure to be given for a longer period of time to keep the lungs open. It is critical because once the lungs start having microatelectasis, then it is very difficult to open them up without intubating. And I'm trying to avoid intubating as much as possible. And you can see that I will usually very rarely go to 8, but yes, the number is mentioned. And of course, I keep a flow. Now, if you are ready to extubate the baby, maybe you've intubated the baby and kept it for 12 hours, whatever, 1 day, 2 days, and you have been able to reach these settings of 16/5 and say 25 rate. And then if that is the situation, then I would extubate the baby to whatever pressure. If you're using 16, I would go to 18 or 20. Again, it is very important to see how much leak the baby is showing. Now, I like to use the nasal prongs. I prefer the Inca prongs because I like the way the Inca prongs stay on the cheeks, and I'll keep some padding on the cheeks so that it's not directly resting it. Hudson can be used, but the Hudson puts pressure on the columella and really pulls up the nose a little bit. And of course, you need to keep a pad or something on the forehead because that's the way the prongs are this thing. If you're going to use Hudson prong for a prolonged period of time, it can lead to something called the pig nose. So that's one of the reasons I avoid it. Draeger prongs are good. Argyle prongs are good. I don't really have any specific push for any of these prongs. I just want to make sure that the nose is protected. I tend to use Duoderm over the nose, over the mustache area, and try to protect. And if I see that there's a breakdown, I will switch over to CPAP, to prongs, to mask. But keep in mind that every time you remove and put something in, you're going to lose some pressure and you will cause some microelectrolysis. So whenever the switchover has to be done, it is a two-person job. Somebody has to remove it, bag it, and the other person then gets ready with the equipment and puts in very quickly so that you do not collapse the lung. That fact is so very important. That is also the reason why I recommend that do not use CPAP as your first line of extubation. Because if you use CPAP and then say the baby is failing, then you say, oh, I'm going to put the baby on NIPPV. Now, the CPAP has already led to a lung collapse, and then you want the NIPPV to open up the lung. Yes, it will open up the lung, but it is not as powerful as the intubation and opening up the lung. So I always recommend as primary as well as secondary mode, and I'll show you again data to back up everything. I've been Cochrane review, updated reviews of that, why it is better. And practically, I'm telling you, if you feel the lungs are so good, you're on 30% oxygen or 25% oxygen, it's okay. Put the baby on NIPPV, put it on lower settings, let the baby, make sure you're doing fine. If the baby doing great, well, continue to wean the NIPPV and get the baby to CPAP. Not a problem with that. Don't rush it. If you do it straight into CPAP and then you want to try to open up the lungs, then it becomes a little bit of a problem. So that's why I recommend use NIPPV as your primary mode or secondary mode after extubation, and then only go into the CPAP or wean down to CPAP as the case may be. This is very critical. I will also highlight here the other art of extubation. I always put an orogastric tube to vent. Now, this is very, very important. But remember, NIPPV, I didn't invent NIPPV. I just modified it and made it hopefully better. Because 1985, Jeffrey Garland published a paper which basically said you can use NIPPV, but the risk of gastric perforation is very high. And then people stopped using it after 1985 till my group and then a group from San Diego pretty much worked independent of each other to show. And we both used the SNP mode compared it with CPAP, and we use the same ventilator, the StarSync, the infant start with the StarSync module. What is important here is that when I was trying to find a better way to do it, because can you imagine when people read the Garland paper, they would be very hesitant to let me allow to put NIPPV in a baby who has a risk for gastric perforation because it can, kill the baby. So we modified it. Synchronization came. I put in the word S before NIP. Not very original, I know, but it works. But the orogastric tube. So I put an orogastric tube. Usually it's about 8 to 9 French. And I will take a 10 cc syringe, remove the plunger, attach it, and then place the whole setup so that the syringe part of it, the proximal part of the syringe is kept higher than the baby. So when the air is being pushed into the lungs of the baby and into the stomach, some air is also able to escape through the venting tube. This venting tube, you can feed through the venting tube. You can give milk through it every 3 hours. It'll go down slowly. It takes about 15 to 30 minutes. No problem. Yes, some air bubbles will come every now and then. Very, very rarely, I have a baby who does not tolerate bolus feeds. Most babies actually do very well with this. Then I will pass another 5 French tube in the mouth. I will actually tape it outside the baby, and that tube will be connected to a feeding tube, connected to a feeding pump that will give continuous feeds. But this is very rare. The point I'm trying to emphasize is that it is very critical to keep a venting tube to avoid the complication of the risk of gastric perforation. I will add here, I have been doing this for more than, well, I don't remember now how many years, more than 25, 30 years. And I get information from around the world about complications. If you do this, the risk of perforation is very minimal. In fact, 0. In my lifetime, so far, I'm aware of only 2 that happened with me. After I told them how to do this technique, in one, there was a small for gestational age baby who was on the NIPPV for 7 days and had gastric perforation. But the baby also had other problems, had got sepsis and stuff like that. So I'm not very sure it was just a technique or something else was going on in that baby. The other baby was a classic baby, fresh baby, freshly born on primary mode NIPPV. I was sitting in my office. I remember it so clearly. It happened when I was at Yale. And then I heard that, this baby had deteriorated, got a gastric perforation, going to the OR. And I ran from my office to find out what happened. And what happened was that it was a new nurse who had been told, or at least given the information about how to handle an NIPPV, but she had forgotten to put in the orogastric tube. I want to emphasize that this story, so that you remember, do not do NIPPV without the orogastric venting tube. It is very, very critical. And I remember the story in my mind and I shared it with everyone that, I mean, of course, the nurse was feeling very bad. Baby did fine. Don't worry. Baby did great. Came back intubated after some time. When the surgeons were comfortable, I extubated to NIPPV and the baby did okay. But the point I'm trying to make is that you have to take these precautions. As far as I know, we have looked into the outcomes of gastric perforation as well as NEC. We have not found any association of using NIPPV with any of these two major complications. And this is from data that have been shared. People have told me across the world. So I think it is a very safe way. It is a very powerful way of non-invasively supporting the baby, but you have to take the precautions so that we don't get into the complications that Garland reported in 1985. This is a picture of a baby before and after NIPPV, and you can see how hazy the lungs are on the top rim. And once I put the baby on NIPPV, I'm able to open up the lungs, and I can assure you the CO2 was much lower in this baby once I did NIPPV. You can modify, you can change the settings of NIPPV based on blood gases, just like you do on a baby who's on invasive ventilation. And these gives you some guidelines of how to do it. If you're dealing with hypoxemia, you can increase the rate, I time. I've given you the maximum values. Hypercarbia, you can decrease I time, increase rate. For hypercarbia and hypoxemia, these are the changes. For apnea, usually these babies are doing okay. Their lungs are normal. So you usually don't need many very high pressures, PIP or PEEP, to handle these babies. But I would suggest that if you are on flow, nasal CPAP, do NIPPV before you intubate the baby just for apnea. Try it. Usually, if you increase the rate and keep the pressures low, these babies do fine. This is my first study, randomized trial that I did, comparing SNP with CPAP. I published in Pediatrics way back, 22 years ago. Wow, that makes me feel old. And I will show you this data, and this has been repeated in most of the studies that I'm aware of. Success rate in keeping the baby extubated for the first 72 hours of life, this is secondary NIP or SNP, 94% versus CPAP. You can look at any study on CPAP, bubble CPAP, ventilator CPAP. One of the largest studies that I know of, and 160 babies in each group, I think, if I remember correctly. The failure rate for CPAP as post-extubation is about 60% consistently. Success rate is 90%. Even when I waited or I analyzed the data when the babies were at time of discharge, even then I had a success rate of about 88%. So this is very, very important. I also want to highlight, even though it did not reach statistical significance, barely, almost close enough, but notice that the PCO2 values are lower in nasal ventilation versus the CPAP. This is my first study I did, primary mode NIPPV. And you will see again a small study. We had to conflict with another NIH-funded study, which I had to stop the study to do that study. And you will notice my primary outcome is BPD or death, and you had 52% on conventional ventilation and 20%, which is significant, and similarly for BPD. What is very striking and important for me to highlight in this slide is this. Look at the duration of SNP. You will notice that even on the babies who were on conventional ventilation, I had SNP. Because I had already shown that SNP is the better way, secondary SNP. This is secondary SNP, post-extubation. So I felt ethically that I had to extubate the baby to SNP when I reached the lower setting. In this group, obviously, the SNP was started soon within the 2 hours of life, whether we got surfactant or not, or whether, within that period of time. And you will notice that obviously there were longer duration of SNP. And of course, there's no significant difference in the duration of endotracheal tube. Even then, no significant difference in the duration of endotracheal tube, no significant difference in the SNP data, yet you had much lower BPD death in the SNP group. That is why I'm highlighting the point.
Don't you want to keep your business? You're not moving your business on that suite. You're going to be left off.
Within a few hours of life. So the timing of extubation out to damage to the lung and how the baby then recovers from that. And we can discuss this in the question answer situation. All right. Primary mode for RDS. Now, CPAP versus NIPPV. Very lovely paper from Ramaswamy's group, published a couple of years ago. NIP was more effective in decreasing the requirement of mechanical ventilation than CPAP. That has been shown over and over and over again. What is important is that in this study, he compared the success rates, or at least the surface under the ranking curve. And you can see for NIP, it is 95%, versus 59 for BiPAP, 32 for high flow, and 13 for CPAP. So again, the confidence, the fact that you look for primary mode for RDS, nasal CPAP versus NIPPV, using NIPPV is better. But NIP was associated with a reduced risk for leak compared to BiPAP and CPAP. You can see the values over here, and resulted in lesser incidence of BPD or mortality when compared to CPAP. Now I'm going to share with you, thanks to Marc-Olivier Duguis. This is updated Cochrane review. As far as I know, it has not been published, but Marc-Olivier kindly consented to let me use his slides that he presented at the PAS 2022 conference. Hopefully the data, the paper Cochrane will come out. So they have done an updated review of comparing CPAP versus NIPPV, and these are the studies that have gone into the comparison. They looked at respiratory failure, defined as all these factors. And once again, you're very familiar with this. On this plot, you can see number 1 over here. To the left favors NIPPV, to the right favors CPAP, and hopefully you can see that the diamond is nicely to the left of this line. And so in favor of NIPPV, the relative risk of 0.63, confidence interval is over there, and the number needed to treat was 11 with a range of 8 to 20. This has taken me how many years? 30 years, 25 years plus, to prove to you guys, to everyone, that if you do the NIPPV properly right at the beginning and try to prevent the tube from getting there, especially in the first 3 days of life, you will decrease BPD. You may not completely prevent it, but you can hopefully at least decrease the severity of BPD. And it's so nice to see this data. Again, I know it looks like the diamond is touching it, but technically it is not, because it is 0.92. So in favor of NIPPV, the relative risk of 0.69, number needed to be 20. So thanks once again to Marc-Olivier Duguis letting me have this slide set so I could share it in my talks when I give it. The other outcomes, no difference in mortality, air leaks, IVH, NEC, which is very important, because I told you that one of the factors that worried me was, oh, if I'm nasally ventilating the babies, would they have an increase in NEC? NIPP superiority only when delivered by a ventilator or a bi-level device. And I want to emphasize this. NIPPV is not the same as BiPAP. And one of the biggest studies that was done on NIPPV, in quotation marks, included BiPAP among the 6 different, and had 6 different ventilators also. That is the NEJM study. And that is my problem. When you mix and match non-invasive techniques, and you don't do it the way that at least I would like to recommend it should be done, then you are not going to get the same results. NIPP, if you have synchronization, NIPP is better. Here, most studies were done around 30 plus minus 2 weeks, or 28 to 32 weeks, so to speak. But I can tell you that my data, at least in the one that I've shown, is in younger, but depends upon what NICU population you're taking care of. And so here, I would recommend, if this is a population you're taking care of now, 28 to 30 weeks and above, definitely do try NIPPV, and you will be very happy with the results when you see it. And once again, get into problem, call me, email me, I'm on WhatsApp, or invite me over if I'll actually show it on a baby how I do it. And I've done that in many NICUs around the world, and happy to do that for you guys too. What about CPAP versus NIPPV versus with combination of MIST and LISA? I think this is very exciting. In my unit, we have actually published a paper. We were part of the MIST study of Peter Dargawel, and so, but we don't have the catheters now. We were trying to do the LISA study, but then that study got canned because the catheter was not functional. There were some issues with the quality control. But this is a very nice study which was published in 2016 from Turkey, and where you can see that they have used MIST versus compared to the others, doing CPAP versus NIPPV. All the other studies have shown NIPPV better than CPAP, but they show even a better response. Now, I will say that if you're doing Ensure, and we do Ensure in our unit right now, but we do proper Ensure, which means intubate, surfactant, extubate immediately. We are not allowing the ventilator to be connected. I do not allow the tubes to be fixed, unless, of course, it's some much smaller baby. You're talking 23, 24 weeks and something else is going on. But for the bigger babies above 20, 25, 26 weeks, If he needs surfactant, we will do the ensure, keep the baby on NIPPV. The baby may get reintubated, but that's okay. But we'll definitely try to keep the baby on NIPPV. If you have the tendency to keep baby connected to the ventilator, even for 1 hour, 2 hours, let's get the lines in, let's get the baby settled in. Then I would recommend you consider Mist and Lisa, because that will prevent you from connecting the baby to the ventilator. High flow nasal cannula versus CPAP. From here, once again, showing you no difference and for respiratory failure and reintubation, but I've already gone over this fact. And I personally, I'm not very fond of high flow cannula because you actually are not able to measure the pressure. With CPAP, at least you know what pressure you're given. And with high flow, you can be delivering anywhere from 4, 5, 6 liters per minute, and the pressures may be generated depending upon the interface, what the baby is doing, 4 to 17 centimeters of water pressure. That has been shown. So I would be wary of using high flow cannula as a general basis. When you compare NIPP with BiPAP in terms of respiratory failure, hopefully you can see the diamond to the left, and compared to reintubation, once again, diamond to the left compared to CPAP or BiPAP, once again showing you the superiority. This is another analysis published in JAMA Pediatrics. All right, I am going to be finishing my talk in the next 4 or 5 minutes, so have some time for questions. Attempt to extubate in the first 72 hours of life. I cannot emphasize this enough. The earlier, the better. Don't be scared. Babies are amazing, and especially if you can give the surfactant early, especially in the first 2 hours of life, however you want to do it, and keep the baby in NIPPV, you will get a good result. Attempt to focus on 24 to 72 hours. That's the window of opportunity to extubate. Do not get scared. If 60 to 70, 50 to 70% of babies will get reintubated, various reasons. They get tired. Actually, there are 3 categories of patients who get reintubated, and I will talk about that. Maybe I can talk about that in the question answers. What are the babies that fail NIP? Because I want to give an opportunity for the question answer to come up. Reintubation at later postnatal ages does not worsen outcomes. I have to emphasize this. Don't be scared to extubate a baby because, the baby will get reintubated, the baby will get tired. We have shown, by the way, that the babies feed very well. As long as you give the same calories, they will grow. In fact, we have shown data they actually feed better. They get to full volume of feeds better when you're on IPPV. The reason we believe that happens is because when you're doing non-invasive support, the degree of inflammation and damage to the lungs is less. The cytokines are calmed down a little bit, and that makes the baby feel better. The tolerate feeds better. You increase the food better. So I think that is part of the reason. But do not keep a baby intubated because you say that they will grow better. They don't. Also, it's important, unless you're in a unit where you don't have a person who knows how to reintubate. That's a separate issue. But otherwise, if you have people who can reintubate a baby, do not hesitate, do not be scared to extubate and use NIPPV. For nasal high frequency, the most studies have used high frequency oscillatory ventilation. Post-extubation, NHF-OV is better than CPAP, probably equivalent to NIPPV, but we need more data on that. Primary support, it's better than CPAP. Not bad. And for NIPPV, again, seems to be no difference. Now, it does not matter what ventilator you use to give CPAP. I will say this. If in your unit, cost is not an issue, use variable flow systems or whatever ventilator CPAP you have. If cost is an issue, use cheap and simple bubble CPAP systems. They're great. Make sure you take the proper precautions in terms of, infection, the water and all is all kept clean. The setup is all this thing. It works great. I don't think they are superior to ventilator CPAP. But if you have a limited number of ventilators in your unit and you want to save it for giving NIPPV, which I would highly recommend, then I would strongly suggest you use bubble CPAP as your method to giving CPAP. CPAP pressures, I tend to avoid more than 8 centimeters. I know there are units in Australia, for example, maybe some in Europe, maybe that we're using high. But personally, I am concerned. Yeah, I know about I'm sure you're aware of the COIN trial. I'm sure you're aware of the increased incidence of pneumothorax. And I know the explanation said it's probably not because of the high pressures, but I find it, especially for the bigger babies, that if I use higher pressures, I have seen enough air leaks that I tend to avoid it. Highly recommend use short binasal CPAP prongs. Do not use long prongs. Mask you can use, but make sure the fitting is appropriate. When you use longer prongs, resistance in the circuit is directly proportional to the length of the tube and indirectly proportional to the force power of the radius. I'm sure you know this physics, right? But if you use the nasopharyngeal prong, if you look at the caliber, it actually starts off like this and then it narrows down. So you can imagine the length is contributing to resistance, plus the fact that it's decreasing the caliber of the diameter of the nasopharyngeal prong, that will increase the resistance. So at least from our hand, and we have tested it, we have published it, It does not. It is not better. In fact, it is more, we found it more problematic, causes more secretion than suction and more blockade, and we have to remove the tube, remove the prong, put another prong. And once again, every time you remove the pressure, baby loses pressure, you get into trouble. In fact, that is one of the main reasons we will all recommend that when you're using Lisa Mist, you have the prongs in place so that once the tube or whatever you're using catheter to give the surfactants taken out, you do not lose the pressure. It becomes very, very important. It is difficult to open up the lungs once they start becoming microectatic. Nasal BiPAP, I personally will tell you the data suggests it may probably not as effective as CPAP, maybe may not be, but definitely NIPPV is stronger and not the same as BiPAP or even CPAP if you synchronize it. High flow is 2 to 8 liters per minute. I think there is a variability in the amount of end expiratory pressure that you measure. And I think at this point, I would recommend not to use it, definitely for primary support, as the NEJM paper showed. And I tend not to use it just because I'm not able to measure the pressure. I will keep a baby on NIPPV and I will move the baby to CPAP. And then I try to get to low flow, 2 liters and then go down. Primary mode SNP recommended as first choice for RDS based on the data that I showed you. Secondary mode recommended as first choice for extubation. Recommendation to control apnea, escalating from nasal cannula to CPAP to NIPPV to avoid intubation. Now, I think the combination of SNP with Lisa Mist is great. I think more studies need to be done, but the data, whatever we have seen so far, is very exciting. One more, I've mentioned few arts of the art of extubation in between my talk. One more thing I want to mention, that loss of pressure is probably one of the most challenging things when you're giving an NIPPV. And so closing the mouth of the baby requires little expertise. When I'm doing an NIPPV, the first time I'm putting the baby, I've told you how I assess the pressure and how the lung expands and auscultation. I will also do a chin lift, close the mouth and see what pressure the machine is showing me. I do not like it. If I want to give the baby 24 and the machine is showing me, 20, 22, 22, 24, I'm fine with it. It's showing me 17, 18, 20, not good. That means I have to find other ways to make sure that the mouth is closed. I use a pacifier. I can dip it in some sucrose. They like to suck on it. I've used a chin strap. You tell the nurse, they are very, very innovative. I had one nurse, I said, find a way to close the mouth, but don't sew the mouth, like don't sew it shut. Don't use like needle and thread. And she came up with this unique, she took the phototherapy, the Velcro goggles, and she connected one on each other with the Velcro and then made a chin strap. It was brilliant. And it stuck to the head, the cap of the baby. And the baby was very comfortable. Again, do not forget, please do not forget to put the venting tube, the venting OG tube when you do an NIPPV. With that, I think my message, this one, it says picture is worth 1,000 words. This slide is worth 1,003 words. That's all, folks. Happy to take questions. If I'm not able to answer the questions, you can check out some of my books and chapters in them. With that, I will stop and hand it over back to the moderators. Thank you so much for your attention. Hopefully, it has been useful for at least some of you, if not all of you. Thanks once again.
Thank you, Professor Vineet Bhandari, sir, for that wonderful lecture. I think you have been able to drive home the messages pretty clearly. And so we have so that the fence sitters, when it comes to usage of NIPPV, I think people would have got convinced by this time. So I think we'll take up some questions. There are many questions in the Q&A box. So the first question is, Dr. Ankit Gupta wants to know about the comparison with nasal, the triple H FNC. I think you have already told us about that. Can you please re-emphasize, sir?
Yeah, so I've already answered that question, Ankit, is the fact that I think if you're using it as primary mode, the answer is no. Do not use nasal high frequency. The failure rate is much higher than using CPAP and definitely much higher than NIPPV that I've already mentioned. I personally do not like to use it even as secondary mode because I worry about the amount of pressure that's being given to the baby depending upon the interface that's been used. So I would recommend do not use it. Till I know there is technology that hopefully will come down the line where they may be able to measure the pressure. And if I can control the pressure that I'm giving, and it's a constant pressure, maybe yes. But at the moment, my recommendation is not. I do not like to use nasal high flow. In my unit, I know there are other attendings who like to use it, but at least I've been able to convince them not to go beyond 3 to 4 liters per minute with Vapotherm in certain circumstances. But yeah.
Yeah, thank you, sir. I'll take up further questions related to the comparison of NIPPV with the other ways of giving nasal non-invasive ventilation. So, Dr. Sakir wants to know, when do we actually use nasal high-frequency oscillatory ventilation in your unit, sir, and your protocol?
Yeah, so I actually do not use, I don't have personal experience of using nasal high frequency oscillatory ventilation in my unit. Like I said, based on the data, it seems to be equivalent to my NIPPV, and obviously I'm very comfortable using NIPPV. But from whatever I have seen, based on the data, people have published, done a couple of randomized trials. People have used it soon after extubation, like secondary mode, right at the beginning, or primary mode. People have used that. From my understanding is that I think if you have an issue with CO2 accumulation, you might like to use that right from the get-go, but I have no personal experience of using an NHOV in my unit. But just like I said, I'm very comfortable and I can crank up the NIPPV settings to get rid of CO2. I've not had a problem with that.
So there is a question from Dr. Rajiv. Is there any gestational age based subgroup analysis comparing NIPPV versus CPAP? Does it NICPV is it superior across all gestational ages, or is there a variation based upon the gestational subgrouping, sir?
Yeah, so the number of studies that have for the smaller gestational age babies between less than 28 weeks is obviously lesser than the higher. But I can tell you, at least in my experience, if the baby can breathe on their own and can handle, and I can assess that right from the beginning, from birth, I will extubate the baby. The ones that I am a little bit hesitant is when I'm dealing with 22, 23, 24 weeks, maybe. The ones that are really, really small, and I'm very hesitant unless I can get them down a little bit. I use what I call the 40, 60, 80% rule as far as the FiO2 is concerned. If I find the baby is requiring more than, if it's starting to inch up from 40% to 60%, I start getting worried. And then I'm cranking up the settings because I really, really want the FiO2 to be down. If I have a baby on high enough settings and I'm on 60, 70% oxygen, I can tell you my risk of re-intubation is like 80%, and I'm prepared for that. But I will give it a shot. I will crank it up as much as. If you want to know what is the smallest baby that I have kept safely extubated for at least a number of days, is actually 468 grams. Obviously, was a small for gestational age baby, X26 weeker. But I think if you're dealing with, appropriately gestational age babies with immature lung, mom didn't get steroid, those babies are a little bit more challenging, even when you've given early surfactant. I try to extubate babies, anyone who is 24 weeks and above, and even some 23 weeks and above, if I see that they have a good drive, and especially if the mom has received antisteroid 48 hours and things like that. But yeah, anything less than 28 and anything more than 23, I will give it a shot.
Yeah, that answers the question. And Dr. Ashok wants to know about experience with using a RAM cannula for delivering NIPPV.
Yeah, so
Ramanathan is also with us. He can also share his own experiences, sir.
Yes, of course.
You can answer, sir.
I think Dr. Ram is also on somewhere here. I tend, and again, RAM cannula has always been very comfortable for babies, and I do get push in for that. I tend to use it. If if the baby is on slightly lower settings. I know Dr. Ram has used it with higher settings. The design of the RAM cannula does involve that you have to keep a little bit less snug, because otherwise the CO2 will accumulate. But I think if there is nasal, little bit of damage to the nose, I will either try to switch to mask, and if that still doesn't work, I might try it. But I usually tend to wait if I can get the FiO2 down. So whatever settings I'm using, if the FiO2 is down to about less than 40%, and if that is happening, then I will use it. But otherwise, I don't routinely use that.
Thank you, sir. I think Professor Ram is no longer with us. I think he is probably logged out. So, I mean,
other responsibilities. Maybe it's gone to the rounds.
As a question, from Dr. Sakir regarding what is the nature of nasal prongs you use in a unit, sir. I think you were mentioning the Inca prongs.
Yeah, so I'm very fond of the Inca prongs that they tend to extend like this, and you can rest them on the cheekbones, because I like the pressure on the nose being distributed equally. I do put in some soft, soft cloth or soft, like whatever the material that you have, that will prevent the prongs to be sitting directly on the skin, like, some kind of spongy material, right? That I think helps. I tend to like that. The Draeger prong, the Argyle prong also have similar design. The one that with the Hudson, you have to keep it on the forehead. And again, you will keep that sponge or like a small square or spongy thing so that it doesn't really hit, but it does really pull the nose a little bit more. I mean, it does definitely give it a snug effect. I think, again, whatever you have, you can use. Just be careful about, and also protect the nose. Very, very important. I take Duoderm or some barrier, and I will put it across the nose. I will take it separate out. I'll make the shape, and do this away from the baby. Please take a scissor, make 2 holes just by the scissor, and then put the prongs in there through the hole, so that then it's very nicely snug. And I will also keep a Duoderm as a mustache. So the prongs are not resting directly on the skin of the nose or on the upper lip. It's very important. I think it protects them. People have, again, the mask is supposed to be less this thing. Sometimes the baby, you see what the baby likes, but my go-to is the prongs before I try the mask.
There is a question from Dr. Sudhir Penugonda regarding the usage of NIPPV. I mean, he wants to know which is the best mode for meconium aspirations. We want to use non-invasive ventilation.
Yeah. So again, I think meconium aspiration, obviously, as you're aware, happens mostly in term babies. These babies are very active and alert. So I think I tend to, start off with CPAP in these babies, because I actually do not like to use non-invasive stuff on them, because they tend to fight a lot, and the risk of air leak does increase. So if I find I'm using higher CPAP, like 6 or 7, I will actually intubate the baby. I just have had bad experiences doing CPAP and NIPPV. I tend to actually avoid NIPPV in the babies with meconium aspiration syndrome, especially if we're talking about full-term babies who tend to fight a lot. Or at least they don't, they just don't like the prongs because the risk of air leaks becomes higher.
Thank you, sir. There was a question regarding air leaks in the NIPPV. Is air leaks, especially PIE, more with the non-synchronized NIPPV versus a synchronized NIPPV, sir? Your thoughts on that?
No data to suggest that there is any. I have published a paper where I compared when I had the SNP versus NIP. I looked at all the outcomes, including air leaks and stuff, no difference. As far as I know, using sync versus NIP has not been shown to make a difference in the degree of air leak, as long as you use it properly. Very important.
Thank you, sir. And there's a question from Dr. Tripti Agrawal. She wants to know what are the main reasons for extubation failure in a unit. Are these respiratory, or is there other reasons for extubation failure?
So I have a paper published on the NIP failure. If you put in NIP failure and my name, you will get the paper. Essentially, to summarize, there are 3 major categories. The first category is the babies who will fail within a few hours. They will fail within 6 hours. And you will see within an hour or 2, I will have a baby. And by the way, I told you how I set it up, and I do it. And I usually leave the baby alone for an hour after making sure that the pressures are properly generated, the mouth is closed, the ventricle tube is there, and I've listened properly. In an hour, I will check the blood gas. And if the blood gas is fine, I will leave it alone. But remember, I always worry about the FiO2. So if I see the FiO2 creeping up, I'm cranking up the settings. Despite all that, I find that some babies are going to fail within 2 to 6 hours. Those babies will fail in the sense that you will find them having either more desaturation, apneic episodes, and you're cranking it up, and you've gone beyond 60, 70%, and I just reintubate those babies. Those babies have too weak muscles. The muscles are too weak, and they are just not able to handle a non-invasive support. And in these, I will intubate, and I will wait for about 5 to 7 days, focus on nutrition, try to minimize the invasive ventilator settings, and try to get them to gain at least 100 grams before I try to re-extubate them. The second category of patients are the ones I really make a lot of effort on. Now, these babies get reintubated after 2, 3, 4 days of being on NIPPV. And some of them, about 50 to 60% of them, I believe, can be prevented. What happens is they have this FiO2 creep. What is happening is that these babies, the nursing staff is very, very critical. They're doing their best, making sure the prongs are there. Sometimes they have to change, bagging, whatever, suction, whatever. So things happen is that the lungs start to have a little bit of microatelectasis. The NIPP is powerful enough. It'll try to open up as much as it can. But this microatelectasis starts accumulating to macroatelectasis. When microatelectasis becomes macroatelectasis, which you can actually probably see on the X-ray if you do one, that's when these babies really start having desaturations. So I try to prevent it, and I'm again watching the FiO2. I like to keep it less than 40%. If I see the FiO2 is creeping 45, 50%, if the baby may look good, the gas may be good, I'm still cranking up the pressures because the baby is compensating as the best you can. But if you don't try to preemptively, anticipate that this baby is going to become from micro, become macro atelectasis, you're going to get into trouble. I'm able to succeed in about 40-50% of these babies by actively telling them, no, if the FiO2 increases, come and tell me. I will increase the settings for that. The third category of babies that fail are the ones who get infected. And these ones, you really cannot do much. I mean, they will just suddenly collapse with a complete cardiovascular collapse. The blood pressure falls. You just intubate, take care of the infection, antibiotics, 7 days, then try to extubate. But again, I have many more details about these categories and stuff like that in the paper, in the publication. If for any, by the way, all of the stuff that I've shown you, except for some of the data where I was thankful for another speaker to give me the slides, share the slide, are published data. Any article you cannot get, email me. I'm easily accessible on the internet. Send me an email and I will send you the PDF of that paper.
Thank you, sir. And there's a question on, if there are recurrent extubation failures and baby requires a re-intubation, second intubation, is there a increased chance that this baby will have a higher mortality or IVH?
No, absolutely no. Again, I will always emphasize, if you use the NIPPV technique the way I have described it, you have maximized the way NIPP is being done, it is not going to increase your risk of PPD. Regarding IVH, I have not read any study where there's been association of increased IVH in NIPPV compared to any of the other modes of ventilation that we have talked about. So I would not worry. As you know, NIPP risk is maximum in the first 3 days of life, and I am pushing for you to use NIPPV earlier in the same time frame. And we have done many studies, other people, Brazil, China, India, people have done studies. We have not seen an increase with IVH or any association with increased IVH.
So, for some more questions, sir, can I call upon my co-panelist, Dr. Murli Raj, to actually take over, sir?
Yes, thank you, Sridhar. Thank you, Sridhar. And thank Professor Vineet Bhandari for this excellent presentation, which is a perfect blend of evidence with a lot of practical points and also your personal experience. Sir, there are some questions in the question answer section, because majority of we prolong this intubation with the fear of this extubation failure. So Dr. Sandeep Telwani want to know, he usually encounters a lot of this laryngeal edema following this extubation. So what are the ways to prevent it and manage in the post-extubation period?
I'm sorry, ask that question again.
Yeah, but it's about the post-extubation laryngeal edema.
Edema. Actually,
Yes.
I haven't seen that because as I mentioned to you, I'm very aggressive in doing it early enough. But yes, if you do have laryngeal edema, I will try a racemic epinephrine. And if I see this baby at a higher risk when I'm trying to extubate the second time, I will give the 3 doses of dexamethasone, 1 or 2 doses before and 1 or 2 doses after extubation to try and diminish that and prevent it. I have actually, in one case, I have to tell you the story. I had a baby that had laryngeal edema and was getting ready to get reintubated. We have tried racemic epinephrine, had steroids on. I put the baby on Heliox. As long as your requirement for oxygen is less than 70%, you can actually put in Heliox with your oxygen tubing. Talk to your respiratory therapist. I'll use the Hindi word. I use Jogar all the time when I'm in the USA, but in India, I think they do it much better than what I do it. But I had a good respiratory therapist, and I was able to get a Heliox attached to the system of NIPPV, which is the regular ventilator, and I was able to prevent the baby from getting intubated. So racemic epinephrine, steroids, yes, and Heliox, especially if the FiO2 is less than 70%, try it. Avoid the tube if you can. It works.
Okay, thank you, sir. And a lot of people have asked about the feeding during the time of NIPPV. So
Yeah.
during this, you already told that you have to put a venting tube. So you would like to put an additional feeding tube to that stomach, and also if the baby NPO for how many times?
Yeah, so the venting tube is used as a feeding tube. So physiologically speaking, bolus feeds are much better than continuous feeds. It has been shown beautifully by Alan Lucas way back in 1978, I think published in Lancet. So we know that it helps better for the enzymes and the growth of the villi and stuff like that. So I will feed the baby through the venting tube. You know, you have the OG tube, you have the syringe, and it's kept above, right? Only the proximal part of the syringe, the plunger is thrown out. You drop in 1 cc, 3 cc's, whatever it is, it will drip down. And you do that every 3 hours. Like I told you, most babies, they feel better because their lung inflammation, I believe, is better. And there is data to back that up, animal data also to back that up. We will feed through that. You can go to 3 ml, 10 ml, even 10 ml. If you have to give 20 ml, which is rare, you know, bigger baby, you can do it in 2 different aliquots. So I feed through the venting tube, which is also my feeding tube. In the rare situation where the baby is having distension, despite this, or the feed is going back and forth and not finishing over the period of 20 minutes, 30 minutes, 1 hour, whatever, then I will put in a 5 French tube. And I will put along with the, so venting tube is there, 5 French tube is there, and I will actually tape it because to remind the nurse that both these tubes are very important. Don't remove one or the other, keep them together. And the 5 French tube is connected to a feeding pump, and then you can feed the baby continuously through that. But this is rare. I will highly recommend the venting tube to be used as the feeding tube. Try it. If it doesn't work, then you can go to this 5 gauge, 5 French feeding tube connected to a pump for continuous feeding.
Okay, sir. A lot of people have asked about other treatment modalities like oral vitamin A in prevention of BPD, and also caffeine. Also
doesn't work. Ambalwanan and other folks have done the studies on this thing. If you want to give vitamin A, it has to be given IM 3 times a week, 4 weeks, to, you know, and you have to treat about 14 to 15 babies to save 1 baby's BPD. So there is no other way. People have tried different things, less dose, high dose, oral, whatever. As of now, the only way vitamin A works is through that.
Okay, sir. Dr. Manish has asked about the use of NIPPV in neonates with the features of shock or hemodynamic instability. So that ask.
Not recommended. Do not use it. If you are in shock or in hypotension, these babies do not tolerate NIPPV. You will have to intubate the baby, get them out of shock, give them a couple of days of fluids, resuscitation, antibiotics, whatever you need. Shocked babies on cardiovascular collapse will not do well on NIPPV. Do not try it. It doesn't work. They'll fail very, very quickly.
Okay, sir. Another question is about the concept of rest in NIV, that maybe meant about this passiveness or sedation you use in sedation. Babies.
I do not sedate babies on NIPPV. In fact, in my unit, baby is born, you know, stabilized and all that kind of stuff. We get vitamin K at birth in the DR. Eye prophylaxis. Once they come to the unit, they get ampicillin, gentamicin, and the 5th drug they get is caffeine. I'm very fond of caffeine. I use caffeine for long periods of time. Again, read up some of the articles that we published on caffeine and how to use it. It's also in the textbook. There's a full chapter on caffeine and we use much higher doses. Nowadays, recommendation is that as the baby grows, you can use higher doses. So caffeine, yes. Sedation, no. If I get a baby who's agitated, which is not very often, again, remember that pacifier with the sucrase, it seems to calm the baby down. In majority of the babies, even though it's not synchronized, the baby figures out the NIPP is actually helping me breathe. They will, to some extent, synchronize with the machine, and they will feel comfortable. I do not sedate because then that will affect the respiratory drive or depress the respiratory drive.
Okay. Dr. Mayank Priyadarshi has asked about the incidence of PAE, the NIPPV. Now he wants to know how do we decrease this pulmonary interstitial emphysema with the NIPPV?
Yeah, I'm not aware of any studies where they have had babies with PIE and they have used NIPPV to see if it makes a difference or not. I can tell you that NIPPV per se does not increase the risk of any type of air leak, pneumothorax or PIE or pneumopericardium or anything else when you compare it with other forms of non-invasive support. Okay, but I do not know of any study that has looked at the treatment of PIE by using NIPPV versus invasive stuff, or like say with the oscillator or something like that. I am not aware of any studies.
Okay. Another question is about the use of NIPPV in suspected NEC or babies who have recurrent apnea.
So,
So you want to know the vaccine.
Yeah.
NIPPV in a 27 week.
Yeah, so I mentioned to you already that NIPPV per se does not increase the risk of NEC. That has been shown. Many studies have shown that. If a baby has NEC, would I routinely intubate the baby and avoid giving NIPPV? So I'll answer the question this way. If the baby has definite NEC with pneumatosis and stuff like that, probably yes, because if the baby is not doing well, the blood pressure is a little bit fluctuant and the FiO2 is climbing up, I will tend to intubate. If the baby is in the suspect NEC mode, then I will keep the baby on an NIPPV. Sometimes I have, since the baby is going to be NPO anyway, I have changed the venting tube with a Ripogal to keep it suctioned out. So I think I let the baby decide. With suspect, maybe yes. With definite, probably no.
So another question is data from your unit. Sir, what is the common causes of extubation failure in your unit? So should we take extubation failure as 72 hours or extend up to 7 days? That's the question from
extubation failure using NIPPV?
No, sir. Common causes of extubation failure in your unit.
In my unit, post-extubation, not primary mode, secondary mode you're talking about, right?
Yes.
I haven't analyzed the data from the unit I'm working right now, but we have analyzed the unit in the other places that I've worked. I showed you the data, depending upon the timing of extubation that I'm using. So if I try to extubate within 1 to 3 days, and the data that I showed you from the first couple of slides on my presentation, that data is during the entire stay in the NICU. So if I extubated a baby and day of life 1 to 3, and the baby got reintubated, that reintubation is during the entire stay in the in the unit. So obviously, depending upon the different categories of stuff, I cannot categorize them in less than 72 hours and this thing, except for the individual studies. But overall, it is for the smaller babies, less than 28 weeks, it's probably in the range of about 60 to 70%.
Okay. Dr. Rajiv Malhotra wants to know whether this, sir, I already told that there is no problem in repeated intubations.
I'm sorry, Oscar, what is the question again?
Doesn't that recurrent intubation increase the chance of ventricular hemorrhage? Dr. Rajiv Malhotra wanted to know.
I see on
recurrent intubations increase the chances of IVH.
IVH, there is no incident, no association with IVH. So if you have to reintubate a baby who failed an IPPV, does it increase the risk of IVH? The answer is no. No difference. Does not impact. Risk of IVH becomes much less after 3 days. And remember, we are giving vitamin. We have an IVH prophylaxis team or prophylactic bundle over here, which I'm sure other places may be having it too. But we give vitamin A at birth. We try not to move the baby too much and do all the other normal stuff that we try to do to prevent IVH from happening. I mean, it still happens. But as far as I know, I'm not aware of any study where it says just because you need to reintubate a baby 3 days later or 5 days later, you are increasing the risk of IVH.
Yes. Dr. Ankit want to know the criteria for stepping up to a high frequency ventilation when this conventional ventilation doesn't seem to yield results.
I'm sorry, where's the...
So when you step up to HFOV from a conventional ventilation, so what are any criteria or consensus is there?
About using HFOV versus conventional ventilation?
Yeah.
Okay, all right. So in my unit, so I know there are certain units in the US that use high frequency oscillatory ventilation as the primary mode, or even jet ventilation as primary mode. These are mostly for the really, really small babies. You're talking about 22, 23, 24 weeks. And like University of Iowa, for example, uses that. In my unit and where I've worked so far in other places, we have always used HFOV or HF. We have both of them, a jet as well as the oscillator. We will use it only as rescue mode. Our indications are that if the baby exceeds a certain amount of mean air pressure, or if the baby, the CO2 needs to be eliminated, then we will go for the oscillator. Remember, between the oscillator and the jet, the oscillator is much better at doing the CO2 elimination. One of our group in my faculty is very fond of the jet, so she always puts the baby on the jet if she needs it. I'm very fond of the oscillator, so I always tend to go to the oscillator because I actually had introduced the oscillator at University of Connecticut NICU when I was there, and also at Albert Einstein. So I'm very familiar with it and comfortable with it. But I think if I want to focus on the CO2, I tend to go to the oscillator. If the baby, if I put the baby in the oscillator, baby doesn't do well, I will switch the baby to the jet. Try to get a better oxygenation, because the jet works a little bit differently than that way. So the indications are if they exceed a certain mean airway pressure, it's usually more than 14 in a bigger baby, more than 1,000 grams, or more than 12 in a smaller baby, less than 1,000 grams. If the baby has PIE or pneumothorax, also we will switch the baby to high frequency oscillation from conventional ventilation.
Okay, sir. So another doubt is the outcome with the different types of interfaces. Dr. Sunil Agarwal wants to know.
Yeah,
what is the...
I already mentioned to you in terms of interfaces, use prongs, use the short binasal prongs. The next choice, and I gave you the names of some of the prongs. I don't have any specific interest, whatever makes it snug. It is important that it should fit in well, and it should not be completely touching the skin directly. So you try to prevent the damage to the to the skin of these babies, whether it's on the cheekbones or on the nose area. So those are criteria that I tend to use, but it needs to fit in nicely so that the pressure that you're giving is going into the lungs as best as possible. And I already mentioned to you what we try to do to close the mouth. Do not use long nasopharyngeal prongs, please. Do not use that. It creates more problems and does not work very well. Yeah.
Also, there is any difference in the pressure delivery between this synchronized and non-synchronized positive pressure ventilation?
In terms of the pressure delivery, I don't know if people have looked into that. I know the study that I've looked into synchronized versus non-synchronized. They've looked at the work of breathing and stuff like that. What I will do mention that, if you close the mouth properly, if you make your best effort to close the mouth and make sure chin lift, chin strap, whatever, all the different techniques I told you, that's where the art of extubation comes. The nursing is very, very, very critical for this kind of success. If you do that, the pressure loss will be within the 2 to 4 centimeters. And if you need to give higher pressure, just crank it up. If the baby needs 22 and you're not getting it when your pressure is 24, go to 28 and make sure you get the baby to get, the baby is at least seeing 22 at that point. That's the way I would do it.
It's already 9 o'clock. Shall we continue?
It's up to you. If you have, I'm okay. Let me see. It's up to you guys. If you have more questions, or they can email me.
Yes. Manoj?
Yes.
I think we will continue for another 5 more minutes. If it's okay with Professor Bhandari. Shall we continue for another 5 more minutes? If it's okay with Professor Bhandari.
Sarah said, okay.
Yeah, I can answer a few more questions.
Take 2 more questions.
Yeah, any more questions?
I can look into the chat and see, anything that I've not tried to cover. Okay, I've talked about that. Yeah, vitamin A, continuous feeds, perforation, caffeine. Maximum dose of caffeine, I will use as high as 20 milligrams per kilogram per day if the baby needs it. But we start the usual 5 to 10 and we go up like that. Talked about HFOV, steroids. Any reduction in steroids for BPD diagnosis? We have not analyzed that data, but obviously I use steroids only in the evolving BPD, like I call them, around 3 to 4 weeks of life. But that is as for extubation purposes. And then we will use what is usually commonly called the Bhandari regimen, which is actually not me, it's my wife's regimen, where we use prednisolone over 7 to 10 days in the baby with established BPD. And that regimen are pretty much the only steroid regimens that I would use in a baby. Reintubated babies increase in morbidity in those extubated in the first 3 days. The answer is no. There is no increase in morbidity. In fact, as I mentioned to you, the BPD is maybe less. Talked about RAM cannula. We talked about death and BPD. We talked about shock, nasal prongs. I don't know what he meant by concept of rest in NIV. I do not know what that means. Thank you, Livette from Argentina and Bolivia. Venting can be used for, we talked about feeding. I talked about meconium, PIE, tachypnea. If baby is extubated and O2 are okay, but baby has tachypnea, you will go for intubation or wait. This is from Nadal, and the answer is no, I will wait. If the CO2 and saturation are okay, I will wait. I will wait unless the baby starts having apnea. Again, there are very specific criteria that I use for reintubation. NEC, we talked about NIPPV, PIE, maximum settings, I have told you already. Extubation failure, we talked about. IVH, we talked about. Change cannula, change nasal cannula and nasal mask. Like I said, unless the baby is having some breakdown, Surinder, yeah, thanks. Unless there's breakdown, I usually like to stick to the prongs. Pictures of how you fix interface, different masks. Picture will give more. I don't have a picture I can share immediately, but email me. This is from Svetal, and I will try to send you a picture of that from one of my other studies. Okay, and someone pay from KCA SNP. I mentioned no sedation, please. Recurrent lung collapse, I talk about. Hourly feeds, that's fine. As long as you give bolus feeds. I'm against. Do I have a use for high flow indication for flow? Like I said, I don't like to use it, but if I have a problem with giving CPAP and I'm on lower oxygen, you might use it. You might want to use it. I definitely don't use flows more than 4 liters per minute. Paracetamol, while on paracetamol, if Raji said triclopher does not decrease respiratory drive, yeah, if you feel that if the data suggests that sedation does not affect the respiratory drive, you can use it. I personally don't have experience with it. I talked about IV caffeine, putting baby on PSC mode before health center. Yes, you could try that. I haven't done that routinely. Like I said, there's only 1 or 2 studies looking at nasal pressure support ventilation. I think Bankalari published one paper. Again, limited experience. Mail ID. Mail ID is Bhandari-Vineet@cooperhealth.edu. Again, just put email Vineet Bhandari, Cooper Health, and you will get it. No problem.
Dr. Bhandari?
Yeah.
Dr. Bhandari, so let me ask. I was just going through respiratory variability index and heart rate variability as markers for extubation success. And there was something about TTI, time tension index, or SBT, spontaneous breathing trials. So how come these things can be used to assess the success of extubation from a conventional ventilation, if not from an IPPV?
Yeah, I mean, there are different criteria. There's an extubation.net. If you go, there is, trying to predict which babies get extubated. I will tell you one thing, that in the first study that I did, I actually did lung function on these babies before I extubated them. So I classified them that if the baby had airway resistance higher than a certain number and a lung compliance less than a certain number, I call them bad lungs, and the other ones I call good lungs. And I looked at what happened if I extubate them to NIP or CPAP. What I found is that even with the baby with bad lungs, the one that had less, like high compliance and high resistance, low lung compliance and high resistance, I had 70% success. 3 out of 10. Yeah, 70% success with NIPPV and 30% success with CPAP. So my suggestion is that I don't really have a good way to predict which babies will succeed on NIPPV as of now. I can tell you that if the baby is a female, if the baby is weighing more than 750 to 1,000 grams, the baby will do better. That much I can tell you. The bigger the baby and female, the better the chance of success. But at least based on lung function, I was not able to predict. I'd say try it out. It's a powerful technique. Use it, try it, maximize it. And I think you will succeed in most of them. Yeah.
Anything about spontaneous breathing trials?
Spontaneous breathing, not recommended. Please do not do that. If you put a baby with a tube and you keep it for 5 minutes, I'm telling you what I just told you, resistance increases dramatically. You don't believe me? Take a straw, put it in your mouth and try to breathe through it, and you will understand what I'm trying to say. I don't use it, not recommended, does not help in predicting which babies will succeed or not succeed. And I don't really have a magical way of predicting which one will succeed. Yeah.
Good.
As we come to the end of the questions, now may I request Dr. Surendra Singh Bisht, the Secretary General of NNF India, to propose a vote of thanks.
Thanks. It's a treat to listen to Dr. Bhandari always. And from the experience and from the work he has done, it says so much. And I think you must have converted all of us to start NIPPV as our primary mode of respiratory support in all babies, and certainly for extubation and secondary mode. As of now, also we are using NIV. So we will certainly switch to NIPPV. Now from yes sometimes, we will be yes always. I think Manoj, we owe this to Dr. Bhandari. All of us owe this to Dr. Bhandari. Thanks a lot, Dr. Bhandari, on behalf of whole of NNF. Thanks Manoj, Girdhar, Murli, and I've seen so many of faculties over there. Somushi is there, and I saw international faculties. Dr. Jashi Bondkar was there, and everybody was there. And I thanks all of them to join for this Learn with Legends webinar series next, which has brought practical tips. And this was the most practical lecture we had. You were talking from your heart, your experiences, and that was going straight into the mind and heart of the people. They are going to practice it, sir, certainly.
Thank you so much. Thank you so much. Take care. Bye now.
Thank you, sir. Thank you.
Thank you, everyone. Bye-bye.
Also, thank you both the moderators for moderating the session so well.
Yes, sir. Sir, can we have a brief announcement regarding the next talk and also the certificate, sir?
Please go ahead.
So the next lecture is scheduled for 20th of April. It's going to be on neonatal seizures, current practice and future perspectives by no other than Professor Ronit Pressler from Cambridge University, UK. Please join us, the delegates, in large numbers for this and spread the message across also. And people who want the certificates and also the creditors, the link to getting that has been posted in the webinar chat. So just copy that link and open it and do the needful. It will guide you regarding what needs to be filled up, and the payment needs to be done and the certificate will reach you. So anything else, sir, Professor?
Yeah, I think a wonderful session, a bit prolonged, but then I think everybody enjoyed it.
Thank you. Thank you. Thank you, everybody.
Thank you, everyone. Thanks for
Holiday day. Have a nice time. Bye. Until 20th of April.